Christopher?
Yeah. Yes.
Hey, how's it going?
Good. How are you doing?
Good. I was hoping I wasn't on the wrong link because I didn't see anybody there.
No, they usually all kind of pile in at the very last minute.
That's all right.
Sometimes I question that too. I'm like, am I in the right place or
My
did I
video's
not get the memo?
my video's not working for some reason.
Hi, Atul. Hi, everybody.
Hey, how are you?
Good, how are you?
I'm good.
Well, are you able to screen share your slides? Does that work? Okay, great. Just want to make sure it was working. Just give it another minute and then we'll get started. All right. Okay, hi, everybody. We'll go ahead and get started. It's my pleasure to welcome Dr. Atul Malhotra to our sleep medicine grand rounds today. Dr. Malhotra is well known to all of us in the sleep medicine community. I could spend 10 minutes introducing him, but They'll just let you know that he's a board certified pulmonologist, intensivist, and research chief of pulmonary critical care and sleep medicine at UC San Diego. He's a professor in the Department of Medicine. He served as president of the American Thoracic Society in 2015, 2016. He is the principal and co-investigator on a number of NIH-funded grants related to sleep apnea. Has published numerous times in the New England Journal of Medicine, including being first author on the landmark studies on tirzepatide. So with that, I will turn it over to Atul. We're really excited to learn from you today about pharmacotherapy for obstructive sleep apnea.
Great, thanks very much, Anita, and thanks for having me here today. I'm going to talk about sleep apnea pharmacology. Do I have the full hour, or what's the duration I'm allowed?
Sorry, I missed that.
Do I have 1 hour, or should I keep it shorter?
Nope, you've got an hour. Yeah, go
Okay,
for
so
it.
we're going to talk today about sleep apnea pharmacology. There is a relevant disclosure here, which is Eli Lilly funded the SURMOUNT-OSA study I'll talk about. I'd like to start out by talking about the global prevalence of sleep apnea. We published this about 5 years ago now, estimating about 1 billion people worldwide with obstructive sleep apnea. This is based on apnea-hypopnea index more than 5 events per hour, which is a fairly liberal definition. Even if you use a strict definition of 15 per hour, we're still talking about 500 million people worldwide where there's really no debate that they need treatment. So whatever approach we take to sleep apnea has to think about that global burden of disease. And that problem is getting worse, not better, with the obesity pandemic and the population growth and aging of the population. Some people say, who cares? Why does it matter if there's all these people out there with sleep apnea? Unless they come to clinical fruition, maybe just leave them alone. So we published this study in the Lancet Respiratory Medicine about 10 years ago now. Raphael Heinzer, my former trainee, was the first author on this. What we did is we went into the community in Switzerland and did polysomnography, not home testing, but polysomnography in the homes of people in Switzerland. I'll point out there's a lot less obesity in Switzerland than there is in the United States, although they're catching up. And in that context, about 23% of women, about 50% of men had evidence of clinically important sleep apnea. That was an AHI over 15. And again, you might say, who cares? If they're not coming to clinical fruition, leave them alone. Well, in a multivariate analysis, the apnea-hypopnea index was predictive of hypertension, diabetes, and depression, all diseases we take quite seriously. So it's hard to argue that we should ignore these people and wait for them to come to clinical fruition when they're afflicted with important conditions. I'm not saying sleep apnea is causing all these conditions, but it's hard to say ignore these people when they're suffering. So there's a concept here that sleep apnea is highly prevalent, but not all are likely to get cardiovascular benefit from CPAP. Why do I say that? It would surprise me if 50% of men in Switzerland had cardiovascular benefit from CPAP, because not all are at cardiovascular risk. Some will die of cancer, some will die of Alzheimer's, some will die of cardiovascular disease unrelated to sleep apnea. And so it would surprise me that the one-size-fits-all approach of giving everybody CPAP is going to work. So the take-home message so far is that sleep apnea affects up to 1 billion people worldwide. That number is increasing, not decreasing, with the obesity pandemic. The numbers vary with scoring criteria and the equipment used, but we need to consider how to address this global burden of disease. So many of you will be familiar with the SAVE study published in New England Journal 9 years ago now. This is looking at CPAP for prevention of cardiovascular events. And the bottom line is it's a negative study. Therapy with CPAP plus usual care, as compared to usual care alone, did not prevent cardiovascular events in patients with moderate to severe sleep apnea and established cardiovascular disease. There's lots of reasons for that finding. It was a well-done study given the constraints that they were working with. It was done largely in India and China where adherence wasn't great. They aimed for about 3 hours per night of CPAP adherence, and they did achieve that. But for me, there are at least 4 take-home messages here. We need better therapies and better adherence. They achieved their adherence targets, but maybe 3 hours per night is not good enough in terms of adequate consolidated sleep. We need to identify high-risk patients better. As I say, giving 50% of men in Switzerland CPAP treatment is not going to work in terms of preventing heart disease. We need more basic research regarding mechanisms, which is a shameless plug for my lab. And we need to treat the underlying cause, at least in some cases, that's obesity. We kind of ignore that with these sorts of studies. So different therapeutic approaches to sleep apnea will be relatively superficial in some of these, but you can use CPAP to hold the airway open. You could use oral appliances or surgery. You try to treat the underlying cause of the sleep apnea. There's lots of weight loss interventions we'll talk about. You could try and promote upper airway muscle tone. You could stabilize control of breathing. There are treatments to facilitate PAP therapy like hypnotics and nasal patency. treatments to improve symptoms and treatments to block complications we'll touch on kind of superficially. So often these kinds of talks end up into CPAP bashing sessions, and I want to avoid that particular approach. I think CPAP is really good treatment for many patients, and it has transformative benefits for some patients. And the idea that nobody tolerates CPAP is simply wrong. So we published this in Chest about 7 years ago now. This is from MedXCloud. MedXCloud is an academic industry partnership. It's funded by ResMed, but I don't take money from ResMed or from MedXCloud, but they did donate to my university. There's about 23 billion nights of data on the cloud now that we can use to analyze for various different analyses. So this was based on almost 1 million patients, where we propensity matched a group that was getting usual care, another group that was getting active patient engagement using modern technology. On the x-axis here is time, and the y-axis is the cumulative percent of patients meeting Medicare criteria. If you look at usual care, about 70% of patients met Medicare criteria for CPAP adherence, which is pretty good. That beats inhaler use in asthma or anticonvulsant use in epilepsy. 70% adherence is pretty good. If you use modern technology with active patient engagement, where a patient gets a thumbs up if they're doing well, they get helpful hints if they're doing poorly, about 87% of patients meet CPAP adherence criteria based on US Medicare criteria. Now, 87% adherence is pretty good, and so people that say nobody tolerates CPAP or CPAP doesn't work or nobody's going to wear that thing are simply wrong. We did a recent meta-analysis too that was published in the Lancet Respiratory Medicine a few months ago. And this was a bit controversial because we included both randomized controlled trials, which tend to be small, and non-randomized trials. The non-randomized ones have possible bias with healthy user effect and residual confounding and whatnot, but they're much larger studies on much longer scales. And so the sample sizes on some of these are quite massive. Regardless, if you look in aggregate at cardiovascular death on the left or all-cause mortality on the right, you do see an overall improvement in terms of cardiovascular death risk as well as all-cause death risk. It's largely driven by the non-randomized studies, and so you'll see correspondence related to this recent Lancet Respiratory paper where people question the results, but to me at least, encourages further randomized trials and more rigorous research to look for CPAP benefits. In terms of CPAP, it improves symptoms. We know that clinically and from the data, we know it improves blood pressure. For some patients, it has transformative benefits. A defeatist attitude towards CPAP is not justifiable based on rigorous data. But there's general acknowledgement that we need new therapies based on ongoing research, which will be the remainder of my talk. You could consider upper airway surgery, and that can be quite helpful for some patients. I've been working in this space a little bit. In full disclosure, I was a global PI for a LivaNova study called Osprey, which I'm just submitting for publication in the next couple of days. So I can share with you results that are published and by press release. This is the so-called THN3 study that we published in JAMA ENT last year. Alan Schwartz was the first author on this, looking at the apnea-hypopnea index, and the oxygen desaturation index. This is looking at targeted hypoglossal nerve stimulation. It's similar to the Inspire device that got FDA approved back in 2014, but this is a more proximal approach. Proximal nerve stimulation is quicker and easier. It's a randomized study. The STAR trial that was in New England Journal in 2014 was a case series that had a randomized withdrawal, so it was a different type of study design. But using a rigorous randomized clinical trial here, we did see improvements in the apnea-hypopnea index at 4 months and sustained at 12 months, and the oxygen desaturation index also improved markedly. The controls didn't really change at 4 months, and then eventually they were put on therapy. And so the THN3 study was published in JAMA ENT, but it wasn't considered definitive enough, so we did another study, which I'll talk about now. This is looking at proximal hypoglossal nerve stimulation improves sleep disorder breathing, the Osprey study, and this is not yet published, but I can share with you what I presented at the American Thoracic Society meeting. The design of the study was published in Contemporary Clinical Trials in 2022, and I can show you the press releases. LivaNova announces Osprey clinical study meets primary safety and the endpoint results. The manuscript is in preparation, as I say, I'm going to submit in the next day or two. I can show you this because I presented the American Thoracic Society the apnea-hypopnea index response rate based on the Sher criteria is shown on the y-axis. Controls didn't really change. The treatment group in this randomized study had a pretty good improvement at 58%. If you look out to 13 months, there was a response rate of about 65%. The median AHI improved quite markedly. A 68% reduction in oxygen desaturation index is also quite good. And so I can't say much beyond this other than to say there's a randomized clinical trial with high level 1 evidence that's hopefully going to be published in this calendar year. There are other drugs that can be used for treating sleep apnea. So montelukast or Singulair, a leukotriene receptor antagonist that's been used in children. David Gozell and others have been working in this space and do see some improvements with montelukast in kids. I know there's a big pediatric group in Michigan, so I wanted to include that. Okay, so what are other treatment approaches to sleep apnea? I won't have time to do it justice today, but as some of you know, we're very interested in the mechanisms underlying sleep apnea, which can vary. And so people don't all get sleep apnea for the same reason. There's various different endotypes or mechanisms. There's anatomical factors, which we'll talk about. Pharyngeal dilator muscle control during sleep may be abnormal. The arousal threshold has a propensity to wake up. This concept of loop gain or control of breathing that we've done a lot of work in. And then there are other factors as well that may be important mechanistically in sleep apnea. People don't all get sleep apnea for the same reason. And this one-size-fits-all strategy of trying to treat every sleep apnea patient the same has largely failed. Why is that? Well, there are different mechanisms, but there's also different phenotypes, that is clinical expression of disease. So how do I know that? Li-Xuan Yi was in University of Pennsylvania before she joined us in Boston. She's a nurse PhD who published this in the European Respiratory Journal with Alan Pack's group from Iceland in collaboration with folks from Iceland. So the different clinical phases of obstructive sleep apnea, there's a cluster analysis. If you take sleep apnea patients, about a third have disrupted sleep or disturbed sleep, like the COMISA group that has sleep apnea plus insomnia. There's a 25% that are minimally symptomatic or asymptomatic, and there's a 43% that have severe sleepiness. Why do I care? Well, subsequent papers have shown that 43% is at cardiovascular risk, the other groups are not. And the reason that's important is that the one-size-fits-all, just giving everybody in Switzerland CPAP, or 50% of men in Switzerland CPAP, is not going to work because only fewer than half are at cardiovascular risk. So this idea of differential susceptibility based on phenotype is important. There are other treatments for these upper airway muscles, and full disclosure, I was involved in some of the studies with Excite OSA. I don't take money from that company, but it is a disclosure because they were involved in the studies. This is an oral stimulation thing you put in your mouth for 20 minutes a day during wakefulness, and it exercises the muscles. It helps to improve endurance in the tongue, which we've shown is abnormal in people with sleep apnea. And at least on pre versus post design, you can see improvements in the apnea-hypopnea index, as well as in terms of sleepiness, in terms of snoring. We need randomized controlled studies. Some of them are currently being designed. But increasingly, there are data suggesting that this oral stimulation thing may be a viable approach, at least for a subset of patients. So I won't dwell on this slide today because I could spend the whole hour on this slide. But why do these endotypes or mechanisms matter? They may guide therapeutic interventions. So patients have control of breathing problems may respond to oxygen or acetazolamide. Risk factors for sleep apnea may relate to endotypes. So patients with post-traumatic stress disorder, for example, may have a low arousal threshold, wake up easily. Sleep apnea endotypes or mechanisms may predict clinical phenotypes. So we know older people with sleep apnea may have relatively unique mechanisms, which could explain why they have fewer complications than younger people with the same degree of severity. And then sleep apnea endotypes may predict treatment response. So upper airway surgery, we can predict the home runs from strikeouts using some of these endotypic assessments. We can also predict from who's going to respond or fail CPAP based on these sorts of mechanisms. And so this may be important clinically. We're not there yet, and this is not the focus of today's talk, but just as an aside, these mechanisms underlying sleep apnea may be important clinically. So we've looked at other drug treatments for sleep apnea. So S-zopiclone or Lunesto is one we studied some time ago. Danny Eckert in my lab had one of the first papers using that approach with this particular agent. You can see on the y-axis here the apnea-hypopnea index. If you use a hypnotic to raise the arousal threshold, you get accumulation of respiratory stimuli, which can allow the activation of these upper airway dilator muscles and lead to improvement in the apnea-hypopnea index. You can see some patients get into range you might consider cured. All of them are going in the right direction, which is good news. But there's a fair amount of residual sleep apnea suggesting combinations of therapies may be required really to eliminate sleep apnea based on just raising the arousal threshold. There are other concepts we've been studying. So my lab was closed during the pandemic, like many labs. And so Chris Schmickel in my lab sat at home with nothing to do and started doing meta-analyses because he couldn't do physiology. So we published a bunch of these studies on acetazolamide or Diamox. And if you look across obstructive sleep apnea, essential sleep apnea, periodic breathing at high altitude, all these things, there's a fairly consistent effect of acetazolamide or Diamox. Not a home run, it's a base hit or maybe a double, but you can see that there are improvements with acetazolamide in terms of nadir sats, in terms of fatigue and some of the daytime symptoms. There are some side effects, but they tend to be transient and self-limited. So published a bunch of papers on this suggesting acetazolamide or Diamox may be a way to lower the so-called loop gain or stabilize control of breathing. And that may be viable, at least for some patients with sleep apnea, or in combinations of other interventions to target different underlying mechanisms. We've done some more basic work in this area as well. So Nancy Chamberlain is now retired, but she was a neuroanatomist who worked with us back in Boston. And she could do things in rats that were kind of cool. She could inject these pseudo-rabies virus vectors into the tongue of the rat and map the different synapses into the brainstem of the rat. And so this is the brainstem of the rat. The hypoglossal motor nucleus is shown here. The dorsal motor nucleus of the vagus is shown here. The nucleus of the solitary tract is shown here. This so-called peri-obex region is quite interesting. Why is that? What's heavy in chat? What is chat? That's cholinasal transferase. It's heavily cholinergic neurons that are important in terms of mediating upper airway reflexes, including the negative pressure reflex and affecting things. So these are heavily cholinergic, and so some of the cholinergic drugs that are being targeted for sleep apnea may be working through this region. With pinpoint injections, Nancy can modulate the reflexes in the upper airway in this peri-obex region. That's led to some pharmacology. People are familiar maybe with atomoxetine, oxybutynin. Atomoxetine is also known as Strattera. Oxybutynin is also known as Ditropan. That drug combination is now being looked at by Apnimed, which is a company that's released some phase 3 results, which I'll talk about briefly. So if you have low upper airway tone, you can use adrenergic stimuli like atomoxetine in non-REM sleep. With cholinergic mechanisms that are inhibited in REM, you could activate the upper airway muscles that way as well. So initial report in the American Journal of Respiratory Critical Care Medicine did show marked improvements in the apnea-hypopnea index using that drug combination in a single night overnight study. Oxygen saturation is also improved by the combination of atomoxetine with oxybutynin. If you look at aggregate data in 15 patients here, it's a relatively small study, you do see some changes. There's some concerning things here about heart rate goes up a little bit, systolic blood pressure goes up a little bit. So the toxicity of these adrenergic drugs is something that people are keeping an eye on. But in aggregate, this study was quite interesting, albeit a single overnight study. So this company, Apnimed, I don't have any affiliations with that company, but it did spin out of my former lab at the Brigham, and even though I'm not involved in the company. There's a little meta-analysis that showed some improvement in the apnea-hypopnea index, about 28%, which is good, but not amazing. The Mariposa study was published in the American Journal of Respiratory Critical Care Medicine by Paula Schweitzer. That did show some encouraging results, about a 50% improvement in AHI. If you look at it carefully, though, this was the Mariposa study published in the American Journal of Respiratory Critical Care Medicine. They didn't really use an intention to treat analysis the way you normally do in all randomized studies. They did a modified intention to treat, and some of the patients who had side effects and things weren't included in the primary analyses. When we look at actual changes that were seen in this particular study, the AHI primary outcome was reduced from a median of 20.5 to 10.8, so that's an improvement there. But it's not a home run in terms of it was 50% reduction. So I'll show you more about what I mean here. By intention to treat, including everybody, you see patients analyzed in the various different groups here. When you look under the hood, intention to treat is supposed to be all randomized patients. Modified intention to treat is okay if they're missing data at random. What they did here was with people who had side effects in various different groups here, adverse events, 12 patients here, 5 patients here, 5 patients here. They didn't include those. So if you look compared to placebo, the AHI decreased by 5.9 events per hour, which is really pretty modest. And so I was a bit skeptical when I saw this report and wasn't sure how it got through peer review. The intention to treat analysis or modified intention to treat should be the primary focus. So certainly we need more data regarding efficacy and side effects from ongoing randomized controlled trials. But drug treatment for sleep apnea may well be viable based on these data. In that study as well, there were some changes in heart rate that looked a bit concerning. There was no serious adverse events, but there was some hypertension and tachycardia, which we're again keeping an eye on in terms of this drug combination. There was a study in Japan that really didn't show much in terms of AHI with atomoxetine, oxybutynin, so that again was somewhat disappointing, but it did lead to 2 phase 3 studies that are ongoing now. The press releases are out that look encouraging. They're not peer-reviewed, obviously, and so we need to see the data. This AD109, which is the drug combination we're talking about, met the primary endpoint, the mean change in AHI at 26 weeks across a broad range of mild, moderate, severe. Study participants treated with AD109 and a mean reduction of AHI from 55.6% from baseline achieved significant improvements in oxygenation and reduced disease severity. We'll need to say where that number came from, whether they used intention to treat or modified intention to treat, how they modified, but certainly the 2 phase 3 randomized studies have now been reported as press releases, but have not yet been through peer review. So I'll summarize what I have to say about atomoxetine, oxybutynin, saying that is a fairly consistent but modest effects on sleep apnea. Multi-center trials are ongoing and require peer review, obviously. Side effects will need to be considered carefully in the context of hard sleep apnea outcomes, especially compared to other pharmacotherapy. I think also patient-reported outcomes have not been stressed there, and I think we need to look carefully at that. So I'll say a couple other things about other sleep apnea therapy things before I dive into the tirzepatide. So treatments to improve symptoms of sleep apnea can be considered. There was recently a consensus, a Delphi consensus meeting that I had the privilege of chairing with Jorg Stier. And this is like herding cats to get a global consensus on how to treat residual sleepiness in people with sleep apnea. This global consensus is challenging. Actigraphy and multiple sleep latency testing are not available in many countries or parts of the world, and so we couldn't recommend that kind of globally because a lot of people said it's just not available. There was general acknowledgement that about 10 or 20% of well-managed sleep apnea patients on positive airway pressure have residual sleepiness. There was emphasis on primary therapy rather than putting a Band-Aid on the problem, treat the underlying cause. And modafinil or solriamfetol Sunosi may be reasonable for some sleep apnea patients who are otherwise well-managed but having residual symptoms. And so, it's a symptomatic treatment. There are also treatments to block complications of sleep apnea. So if we can't stop the repetitive apneas, maybe we can block the cardiovascular complications. There are various approaches to that. Some people say just give a beta blocker and reduce the effects of the catecholamine surges. We've been looking at some stuff related to the microbiome. So Gabby Haddad is the senior author in this. We have a number of papers here, primarily from rats. There's some background here. TMAO is a choline metabolite. There was a New England Journal paper about 10 years ago where they looked at gut bacteria making this choline metabolite, and that was associated with atherosclerosis. And when they gave antibiotics and probiotics and whatnot, they could affect the TMAO levels and prevent atherosclerosis in that context. We looked at it in the context of sleep apnea. We thought maybe the intermittent hypoxia and hypercapnia could be affecting gut bacteria, and maybe that influences this TMAO. So we looked at that in various different rat models. In room air and with intermittent hypoxia and hypercapnia, so-called IHC. We looked at the aorta, the aortic arch, and the pulmonary artery. You can see with intermittent hypoxia and hypercapnia, increases in atherosclerosis induced by intermittent hypoxia and hypercapnia in the aortic arch. The interesting part is this DMB is a drug that blocks TMAO, and you can see some improvements in the atherosclerosis, both in the pulmonary artery and to a lesser extent in the aortic arch. And so the idea that the hypoxia and hypercapnia may affect gut bacteria, and that may influence risk of atherosclerosis. It's kind of a new concept, but something we're quite interested in. Okay, so the remainder of the talk, I'm going to talk about weight loss, which is presumably why I was invited here today. And so there's various different approaches to weight loss. We published this meta-analysis just before the SURMOUNT-OSA result was released, and some background information in this paper in Sleep. On the x-axis, here's the change in the body mass index. On the y-axis, here's the change in the apnea-hypopnea index. And you can see on the red line, as people lose more weight, their apnea-hypopnea index improves. The more weight they lose, the more their sleep apnea improves. The blue guys are lifestyle changes, diet and exercise. The black dots are bariatric surgery, so they get bigger bang for the buck with surgery than diet and exercise. And the green dots are drug therapies. The SURMOUNT-OSA result, which I'm about to show you, does fall in the red line. You see about a 20% change in body mass index and about a 55 or 60% improvement in the apnea-hypopnea index, suggesting that the improvement in AHI is from weight loss, although there are other mechanisms that may be important as well. The design of the study, the SURMOUNT-OSA study, was published in Contemporary Clinical Trials in 2024. By way of background, tirzepatide is a GLP-1 receptor agonist with GIP. GLP-1 is glucagon-like peptide 1. GIP is gastric inhibitory peptide, also known as glucose-dependent insulinotropic polypeptide. That combination is called a dual agonist. It's somewhat different from semaglutide, which is a GLP-1 receptor agonist that does not have the GIP. Semaglutide you see on TV, it's Ozempic or Rybelsus or Wegovy. This is different. Tirzepatide is Mounjaro or Zepbound. It's a dual agonist that works through several mechanisms. Here's the design of SURMOUNT-OSA. There were two different studies. Study 1 were non-CPAP patients, patients who couldn't or wouldn't use CPAP. Study 2 were CPAP patients who were on CPAP. Both groups were randomized to get either tirzepatide at the maximum tolerated dose or placebo. There's no direct comparison of tirzepatide to CPAP, and so people that try to draw conclusions whether this is better or worse than CPAP, you can't do that based on this study design. We can say tirzepatide is better or worse than placebo, but we can't say it's better or worse than CPAP. Patients were randomized and got to the maximum tolerated dose and studied out to 1 year at the primary endpoint. All patients in both arms were given monthly visits with registered dietitians, including healthy nutrition, as per standard of care, and increasing physical activity over 150 minutes per week. We withdrew the CPAP for 1 week prior to each PSG to see if the drug was working, as opposed to the CPAP, which we know will reduce the AHI when people are wearing it. So the inclusion criteria was age over 18, moderate to severe sleep apnea. So there was no mild sleep apnea, no snoring here. AHI is over 15. BMI is over 30, so nobody was lean, nobody was overweight. You have to have a BMI over 30. We excluded people with diabetes. That's important because people with diabetes tend to lose less weight with GLP-1 receptor agonists than do people without diabetes. We went to the maximum tolerated dose of 10 or 15 milligrams once weekly, given subcutaneously to see if that's superior to placebo in terms of the change in AHI, which is our primary outcome. We also looked at a bunch of secondary outcomes. I'd like to emphasize we controlled for multiple comparisons, so there's no data dredging or fishing trips here. And all the ones I'll show you today were pre-specified. So all were pre-specified, all were controlled for multiple comparisons. We looked at the percent change in the AHI, percent of participants with more than 50% reduction in the AHI, those you might consider cured or in remission where the AHI is minimal or they're mild sleep apnea without symptoms, Epworth score less than 10. We looked at the sleep apnea-specific hypoxic burden, which we know is a cardiovascular risk predictor. We also looked at systolic blood pressure, which is obviously important. We looked at the percent change in body weight, which obviously patients care a lot about. We looked at the change in high sensitivity C-reactive protein, which we know from the Jupiter and other studies is a strong cardiovascular risk marker. We also wanted to make sure we weren't just making the numbers look better, but the patient's feeling better. So we looked at patient-reported outcomes, including the PROMIS sleep-related impairment, that's daytime symptoms, and the PROMIS sleep disturbance, that's nighttime symptoms, in terms of a pooled analysis of study 1 and study 2. I'm going to show you two sets of results. There's an efficacy thing, which is patients who stayed on drug, and this treatment regimen, which is based on modified intention to treat. The two sets of results are almost identical, but I'll show you both for transparency. Study 1 were non-CPAP patients. Study 2 were CPAP patients. Both are randomized to tirzepatide or placebo. The study was quite well done in terms of most patients completed the study. There were some dropouts from the placebo, presumably a weekly injection. Doesn't sit well for people that aren't seeing any weight loss. In study 2, 94% completing the study is really quite good for this type of design. There were some adverse events. Arguably, there were more in placebo than in tirzepatide in study 2. In study 1, there were numerically more with tirzepatide, but very small numbers in both sides. Withdrawal by subjects are very rare with tirzepatide in both study 1 and study 2. There were some withdrawals from placebo, presumably because the weekly injection wasn't fun if it wasn't doing anything. Baseline characteristics, these look like our study patients in terms of what they look like in clinic. So average age about 50, 48 to 52. About 30% were female. That's important because Some bariatric studies are predominantly female because that's who shows up in bariatric clinics. Some sleep apnea studies are predominantly male, so by mandate, we had about 30% females. That's important because women tend to lose more weight than do men with GLP-1 receptor agonists, so that number is important. We had pretty good diversity here. We had about 40% Hispanics, which is quite good. The number of African Americans is lower than you might like, but this is a global study in 9 countries. So there aren't African Americans in Europe or China or Asia for the most part. And so within the United States, our percentages were quite good in terms of African Americans, but globally, it's a smaller percentage because of the other countries involved. BMI is around 39, so this was class 2 obesity. We excluded people with diabetes, but a lot of them had pre-diabetes, and hypertension was treated in about 75% of patients. They had pretty severe sleep apnea. AHI is around 50 events per hour. We excluded mild sleep apnea, so they're all moderate to severe. And they weren't that sleepy based on the Epworth Sleepiness Score. These patients came from bariatric and from endocrine clinics, not from sleep clinics, and so their Epworth scores at baseline were less than what you might be used to in a sleep clinic. So this was published in the New England Journal of Medicine in 2024. When this was coming out, I told my daughter, I have a paper coming out in New England Journal, and she said, "How many times have you been in there, Daddy?" I said, "I don't know, I'll check." I said, "Well, it's 13, but some of them were reviews and editorials and stuff." And she said, 13? Daddy, it comes out every week. So can't please everybody. So look at the primary outcome here. The apnea-hypopnea index on the left is study 1, non-CPAP patients. On the right is study 2, these are CPAP patients. See a marked improvement in the apnea-hypopnea index both in study 1 and in study 2. The efficacy analysis, patients who stayed on drugs shown here, the modified intention to treat shows almost the same result, a marked improvement in the apnea-hypopnea index in both arms, both clinically and statistically significant. Let's look at key secondary outcomes, again, controlled for multiple comparisons, and they're all pre-specified. So let's look at the percent change in the AHI. It's about a 55% improvement in the apnea-hypopnea index in study 1, about a 60% improvement in study 2, similar results in the efficacy and the modified intention to treat analyses. With a more than 50% reduction in the apnea-hypopnea index in 60 to 70% of patients in study 1 and study 2 in the modified intention to treat, but 60 to 75% in the efficacy analysis in study 1 and study 2. So tirzepatide, the maximum tolerated dose, leads to a 50% or greater reduction in AHI in 65 or 75% of patients. If you look at those patients you might consider cured, that's an AHI less than 5, or an AHI 5 to 14 without sleepiness, it's about 40 or 50% in the modified intention to treat, about 40 or 50% in the efficacy analysis. Now, I'm cautious when I show this slide because the word cured has a specific meaning that I don't think we meet. Cured would mean a permanent cure. These patients are staying on drug, and so what happens 5 or 10 years later, I don't know. There are some patients who redistribute body fat or stop taking the drug or whatever, and their sleep apnea may come back. And so the AHI is less than 5. I think you could reasonably withdraw a CPAP on and say they don't need it anymore. That's about 30% of our participants. For mild sleep apnea between 5 and 14, there's lots of reasons we treat that. Epworth score less than 10 might be impressive, but remember they started out with an Epworth of about 11, so it's not that much of a change. There's other reasons we treat mild sleep apnea. It might be for fatigue. As Ron Chervin has showed, that's one of the most common symptoms in sleep apnea. You might do it for blood pressure. You might do it for non-restorative sleep. There's lots of reasons we might treat mild sleep apnea, not just for Epworth score. So I don't say that 50% were cured, which is what some people interpret. You look at the shift in the AHI severity levels in study 1. Placebo, there's some dropouts here, but it doesn't change much. Tirzepatide does lead to marked improvement in severe sleep apnea in red and moderate sleep apnea in orange, markedly improved at 1 year in study 1. Study 2, you see a marked improvement in severe sleep apnea in red, a more modest improvement in moderate sleep apnea in orange. Part of that's the severe cases are becoming more moderate. So it's not that we're not impacting moderate, it's just they're migrating stages here. But overall, there's a marked improvement in AHI severity with tirzepatide as compared to placebo. Let's look at the sleep apnea-specific hypoxic burden, not just the nadir sat, but the magnitude and duration and frequency of desaturations As Ali Azerbaijan has shown, that's a strong cardiovascular risk predictor that's sleep apnea specific. See a marked improvement with tirzepatide in study 1, both in the efficacy and in the modified intention to treat analyses. In study 2, the non-CPAP patients, again, about a 75 or 80% improvement in the sleep apnea specific hypoxic burden. Let's look at cardiovascular related outcomes. Body weight changed by about 18 to 20%. To put that in context, if I was 200 pounds at baseline, a 20% improvement would be about 40 pounds. So it'd take me from 200 pounds to 160 pounds, a game changer. More than 7 inches in waist circumference associated with that as well. And so it's quite a game changer for people to get this medication as compared to placebo. You do see some improvements in the placebo. I don't think that's placebo effect. I think that's from the diet and exercise and the monthly dietitian visits that they're experiencing. High sensitivity C-reactive protein in the modified intention to treat on the left and the efficacy on the right, marked improvements in high sensitivity C-reactive protein, which is known as a strong cardiovascular risk marker that improved with tirzepatide as compared to placebo. Systolic blood pressure changed by about 9.5 millimeters of mercury. That's perhaps the result that surprised me the most. I was quite surprised. They weren't starting out with uncontrolled hypertension. So 9.5 millimeter mercury improvement was more than I was expecting to see. 7.5 in study 2 is also quite marked. Diastolic blood pressure was not pre-specified, not controlled for multiple comparisons. So I won't show you the result, but the pattern was similar. So looking at patient-reported outcomes, again, we want to just not look at the numbers, but how the patients feel. We did a pooled analysis pre-specified for the PROMIS scores. Sleep-related impairment, daytime symptoms markedly improved with tirzepatide compared to placebo. The sleep disturbance score, nighttime symptoms markedly improved with tirzepatide compared to placebo. We have a paper now in press at Sleep Medicine that looks at patient-reported outcomes in much more detail. I'll point out when you're doing these kinds of studies, it's very hard to maintain blinding. When somebody's losing 20% of their body weight, you know what group they're in. And so in isolation, these patient-reported outcomes are kind of meaningless. But with concomitant changes in objective and subjective things, it becomes much more compelling. The FDA and others are very interested in patient-reported outcomes. It's important that we track these, but look at them in isolation is somewhat meaningless because it's not effectively blinded. So summarize the efficacy by saying tirzepatide demonstrates superior and clinically meaningful improvements in sleep disorder breathing compared to placebo, marked changes in the apnea-hypopnea index, patient-reported outcomes, and cardiovascular risk markers, including C-reactive protein, body weight, and systolic blood pressure. So let's talk about safety in some more detail. If you look at treatment emergent adverse events is about 75 or 80% across the board here for both tirzepatide and placebo. They're really quite common in these sorts of patients in both groups here. Serious adverse events are quite uncommon, arguably more with placebo than tirzepatide in study 2, numerically more with tirzepatide than placebo, but small numbers and very little difference between groups here in terms of serious adverse events. We're looking now at study 1. They do have gastrointestinal side effects. That's part of these medications. So nausea, vomiting, diarrhea, constipation, seen about 25% of participants in study 1. Very similar result in study 2, about 20-25% of patients get nausea, vomiting, diarrhea, and constipation. The good news is twofold. Number one is very few people drop out of the tirzepatide because of GI side effects. I showed you the dropout numbers are quite small, and so people don't drop out as a result of these. The other thing is that 1 year, these effects have basically gone away, and so if people stick with it, these side effects are attenuated over time. There's some adverse events of special interest. We're worried about medullary thyroid cancer, we saw 0. We're worried about pancreatic cancer, we saw 0. We're worried about death, we saw 0. What we did see, though, were 2 cases of pancreatitis, both with tirzepatide, 0 with placebo. So about 500 patients in total in the study, about 2 in the tirzepatide group got a diagnosis of pancreatitis, 0 with placebo. I'm a critical care physician, as some of you know, and so I did a deep dive on these 2 cases with my critical care hat on to see what was going on with the pancreatitis. I believe what happened here was ascertainment bias. There were very mild cases, and I couldn't figure out why they were diagnosed. And so what happens in some cases is people come in with nausea, vomiting, abdominal pain, and people check an amylase and lipase just because they have those symptoms. And so you end up diagnosing acute pancreatitis more often because of those side effects. These cases are not to be ignored. but it's less than 1%. I do tell my patients that this is something that could be experienced, but it's not something I worry about. As I mentioned, these side effects do attenuate over time. So if you look by the end of study 1, diarrhea is quite uncommon. Nausea is quite uncommon, and vomiting has basically gone away by the end of 1 year. So summarize the safety by saying the safety and tolerability profile of tirzepatide in people with moderate to severe sleep apnea and obesity was generally consistent with safety profile of tirzepatide and incretin-based therapies in people with obesity. The most frequent adverse events were gastrointestinal related, were generally mild to moderate. There were 2 positively adjudicated cases of acute pancreatitis. Both were mild, both with tirzepatide, 0 with placebo. Again, not to be ignored, but not something I spend a lot of time worrying about. So I did present some further results at the American Thoracic Society meetings. I'm allowed to share these now. This is change in the peripheral AHI that's based on WATCHPAT, which we did along the way, and body weight in participants with moderate to severe sleep apnea with obesity from SURMOUNT-OSA. So in study 1, the non-CPAP group, we got periodic WATCHPATs just to see what was going on. And so I'll show you some of the data now, which is kind of interesting. Here's the change in the peripheral AHI, that's the WATCHPAT AHI over time. You do see a marked improvement in the WATCHPAT AHI as compared to placebo, consistent with the PSG results I showed you earlier. What's interesting here is you start to see separation even at 4 weeks. And so often I get that question clinically is how long will it take to respond? And within 4 weeks, you start to see separation. By 20 weeks, you have clear separation with statistical significance. And so this is something I tell my patients. If you look at the percent change in body weight now on the alternative y-axis, it's about an 18% improvement consistent with the overall study results, and less so with the placebo. There's less change in body weight, not surprisingly. You do see concomitant changes in the BMI and AHI. They're not exactly overlapping, but they do kind of parallel one another, again, suggesting that body weight is an important component of the improvement in the apnea-hypopnea index. If we look at the change in the peripheral AHI on the y-axis here, percent change in AHI from baseline on the PSG, they also look quite similar. The WATCHPAT tends to underestimate and overestimate trivially, but basically the results are quite similar whether you use the AHI determined by PSG or the WATCHPAT AHI, just to give some further validation of WATCHPAT. So I conclude the ATS presentation by saying the SURMOUNT-OSA Study 1 non-PAP patients, measurement of peripheral AHI by WATCHPAT with WATCHPAT demonstrate clinically meaningful improvements in sleep disorder breathing with tirzepatide in adults with moderate to severe sleep apnea and obesity. Significant improvements were observed as early as 4 weeks, although statistical significance was seen at 20 weeks. As I mentioned, you see separation at week 4. Reductions in peripheral AHI were accompanied by statistically significant reductions in body weight. Data from this analysis confirmed the clinically relevant improvements reported from the PSG-based data. So sometimes people hear this talk and say, well, this is the end of our field. We don't need sleep specialists anymore. We'll just have primary care inducing weight loss. And so I published this in the Lancet Respiratory Medicine about a year ago, just to calm people down, saying that CPAP is here to stay. I started the talk by saying that there are major benefits to CPAP, and I don't want to underemphasize that. Some sleep apnea patients are lean or overweight, so they were not included in SURMOUNT-OSA. Some have huge BMIs and they won't lose enough weight to get resolution of their sleep apnea. Some lose weight and they have residual sleep apnea, as we've seen in various different studies, including bariatric surgery ones. Some lose weight, then regain it. Some lose weight and then reacquire sleep apnea as they redistribute body weight. And then the bottom line take-home message is I think treating both sleep apnea and obesity is optimal for metabolic outcomes rather than treating either one alone. So we didn't take on CPAP as the standard of care or as the gold standard treatment or as first-line treatment. We did non-CPAP patients, tirzepatide or placebo, tirzepatide patients or CPAP patients, tirzepatide or placebo. So the standard of care, in my view, is still treating both sleep apnea with CPAP and obesity with whatever means you have, including tirzepatide. The Cherno study in New England Journal suggested that treating both was better than treating either one alone. So key takeaways, tirzepatide maximum tolerated dose demonstrates superior and clinically meaningful improvements in sleep apnea-related sleep disorder breathing. Tirzepatide maximum tolerated dose demonstrated superior improvements in patient-reported outcomes and sleep-related functioning. Treatment with tirzepatide maximum tolerated dose translated to clinically meaningful improvements in sleep apnea and obesity-related cardiovascular risk. The safety and tolerability profile of tirzepatide, people with moderate to severe sleep apnea and obesity, was generally consistent with the safety profile of tirzepatide and incretin-based therapies. Mediation analyses, including what is an obesity effect versus a sleep apnea effect versus a direct effect of the drug, are now in peer review at a high-level journal. So I'll conclude with this slide, saying it's an exciting time for the sleep apnea field. For years, we just handed out CPAP machines. Now we have a lot more to offer. Pharmacotherapy isn't just coming, but it's now here. Individualizing therapy may be viable based on endotypes and phenotypes and disease heterogeneity. There's obviously ongoing research in this area, including at University of Michigan. So I'll stop there. I'd be happy to take any questions. Again, it's been my honor to be here today. Thank you for the invitation.
Awesome. That was fantastic, Atul. Thank you. I'll open it up for questions. Feel free to raise your hand, anybody who has a question. Yes, Ron, go ahead.
Bill, thank you very much for bringing that overview, and it's a very important topic. I'm wondering what your own experience has been in clinic, either you or at your center. One of the things that we have in terms of offering therapy with tirzepatide here is we haven't figured out quite how to best to follow them, is you have to see them fairly frequently in the beginning. Are you guys just jumping right in and doing it yourselves, and you manage to see them the way it's required and follow them the first 6 months especially?
Yeah, Ron, it's an important question. And I personally am not heavily involved in this because of my conflict of interest. So I do recommend that people talk to their primary or talk to their endocrinologist or talk to bariatric medicine. One of our clinicians, Chris Schmeckel, is also a researcher in my lab with a K23. He's sort of become our champion just to get more experience with it. So he's seeing these patients regularly. Ideally, they see registered dietitians, which many sleep clinics are not resourced adequately for. Teaching injections is also easier done through endocrine clinics than through sleep clinics. And so there are some issues there. The other issues, some of you know, I'm married to an endocrinologist, and my wife says about 80% of the calls they get in an endocrine clinic are about these medications where people have questions about them, or the insurance denials, or peer-to-peer, this kind of stuff, or the pharmacy ran out of medicine, or this kind of thing. So just the volume of calls is an issue as well. So I think there are some challenges here, but I don't think we should, as a field, run away from treating sleep apnea. I think it's just we need to be adequately resourced to do this, and so we're kind of walking before we run, but I think we are headed that way.
Thank you.
Thanks, Bill. Amy, and just for the group, Dr. Rothberg is a professor of medicine and endocrinology here. So thanks for joining us, Amy. Go ahead.
Oh, thanks, Anita. Yes, so I'm an endocrinologist, so take it from that is my bias. So yes, I concur that we are overwhelmed with calls about these drugs. So please don't overwhelm us further. We are not adequately resourced to deal with all of this. But I was more interested in the phenotypes of sleep apnea, specifically the high loop gain. I'm not really quite sure what that means exactly, but it was an interesting combination of drugs that you were using, acetazolamide, which if I just elaborated that, have you thought, or has anybody considered using in place of acetazolamide topiramate, which would also help to reduce weight, in conjunction with another stimulant drug such as phentermine? Combined, as you know, that is a drug called Qsymia, and that results in weight reduction. And so I thought maybe that would be useful for both this high loop gain and losing weight. And certainly could be a way of off-ramping people from GLP-1s if that became an issue because of the payers onto a less expensive drug. Long question, sorry.
Yeah, no, it's a good question. The short answer is I don't know. There are theoretical arguments that topiramate that it may worsen control of breathing in some cases and things, but identifying those patients with unstable control of breathing and targeting them with topiramate has not been done to my knowledge. And so that's an interesting question. The graph I'm showing you here was all the different pharmacotherapies that have been looked at the time. I believe one of them was Qsymia, if I recall correctly. And so for the most part, they fall on the red line, but I don't know if this outlier here was Qsymia or not. I'd have to double check that. As a personal story, I was at a cocktail party and somebody asked me about topiramate as an agent. And I said, oh, don't take that. It'll make you stupid, because there's some mental slowing that's been reported with it. And of course, that person was on that drug. So be careful what you say at a cocktail party, even after a couple of rounds. So I'll look more into that, Amy, and get back to you.
Thanks.
Thanks, Amy. Thanks, Atul. Shinhan.
Thanks. Well, thank you, Dr. Malhotra, for this great review. So I have two questions. First is, in your opinion, where do you see Zepbound right now among other treatment options? Like, for example, are we okay with providing that as an option in patient who hasn't even tried CPAP or who are unwilling to try it? Or we still would recommend patient with CPAP first and only offer it to those patients who cannot tolerate CPAP? And second question is kind of following Dr. Sherman's question. So I don't know, based on your experience, who are managing the prescription for Zepbound mainly? So as sleep physician, are we supposed to be the one that prescribes medication? So just wondering what's your experience? Thanks.
Yeah, thanks. Regarding first-line treatment, as I tried to emphasize, I think standard of care has not changed. The standard of care first-line treatment is still CPAP. And this editorial in Lancet Respiratory Medicine said CPAP is here to stay. We did not take on the standard of care, which is CPAP. First-line treatment, gold standard treatment is still CPAP. People are
Okay.
talking about head-to-head comparisons of tirzepatide to CPAP as comparative effectiveness, two active treatments to see who wins. Until that's done, the first-line treatment is still CPAP. And I think, I feel fairly strongly about that we didn't take on the gold standard with our design. We did a placebo-controlled study, which is important, but it wasn't comparative effectiveness. And so standard of care hasn't changed. And I think at this point, if somebody comes in to see you with clinically important sleep apnea, you don't offer them CPAP. I think that's not good medicine. That's my opinion. Regarding who manages the prescriptions, as I mentioned, I'm not personally doing it a lot because of my conflict of interest. Chris Schmeckel in our group is taking the lead on that, and he's been getting insurance authorizations and peer-to-peers and doing all that kind of thing. For the most part, our primary care, bariatric medicine, endocrinology are doing more of that sort of management, but it's increasingly a burden that's falling on sleep providers as well. The important part, as I emphasized to Ron as well in his question, was just being adequately resourced. So teaching injections is something endocrinologists do better than we do, but we need to get better at. Monthly visits with registered dietitians is an important part of maintaining skeletal muscle health and all that, which we don't do if we just sort of give people drugs and otherwise ignore them. And so I think it is an important thing. It does vary locally in terms of different things. So some centers, I've heard the sleep providers are taking this on sort of full steam. Other places, they're not doing it at all. They're sending everything to endocrine. I think it depends on the local capacity and local expertise. I have a close personal friend, a family friend who's a primary care physician. Her group doesn't do it at all because they're not comfortable managing the complications and side effects. And so they do it all through endocrinology and through bariatric. I have other friends who are neurologists, sleep specialists who, again, aren't comfortable managing pancreatitis or working up abdominal pain or this kind of thing. So they're less comfortable than some of the maybe pulmonary people with critical care background, but that varies locally. And again, I don't want to put anybody in a position where they're uncomfortable. If people are comfortable prescribing, that's great. The other thing I'll point out, the last statistic I heard is 1 in 7 Americans has tried a GLP-1 receptor agonist. And so it's not something we can ignore. It's here.
Thank you.
Thank you.
Great, thank you. Punita. I think you're muted.
Thank you. Thank you for the comprehensive talk about the pharmacology of sleep apnea treatment. My question is about the central sleep apnea and acetazolamide. Has it ever proven that patients with the central sleep apnea and congestive heart failure with acetazolamide in combination with the PAP therapy showing any effectiveness on improvement of ejection fraction or cardiovascular functions?
Has it been proven that giving acetazolamide to patients with central sleep
Yeah.
apnea on CPAP improves cardiovascular function?
Yes.
The short answer is no, I don't think that's been looked at. There was a New England Journal paper a couple of years ago about acetazolamide and acute congestive heart failure, but their outcomes, as I recall, were primarily related to diuresis. And so it was a way of decongesting the lung and making the extravascular lung water reduced, but they didn't look at hard cardiovascular outcomes with that or even echocardiographic outcomes with that. So we have seen with acetazolamide improvements in central sleep apnea with heart failure. Scotty Sands and I are now working on an analysis that will give some good physiology underlying that. But in terms of improvements in cardiac function, what I can share right now is the answer is no, nobody's published on that,
Thank you.
to my knowledge.
Great, thank you. Jinhong, did you have another question?
Oh, no, sorry, I forgot to lower the hand.
Oh, no, you're good. You're good. Let me make sure. Does anyone else have any questions?
Kathy,
well-
you're not gonna humor me?
Oh, what's that?
Kathy's not gonna humor me with something?
Oh. Just looks like she's saying no. She's letting you off easy. Oh, go ahead.
I
Kathy.
liked your cocktail party story.
Yeah, don't take Topiramate.
So I was just wondering if you could speak more about the role of a dietitian in terms of longitudinal management. I think even separate from tirzepatide, that's something that we struggle with our patients. And just if you have any other considerations for us just in just multidisciplinary care.
I think it's an important question. I think many of us, myself included, were sort of guilty of putting a Band-Aid on the problem. So a morbid obese person with sleep apnea, we gave him CPAP and didn't really do a good job of addressing the underlying cause. And the analogy I use as a pulmonologist is if a heavy smoker comes in with COPD, giving them bronchodilators, not addressing their smoking is not very good medicine. That's for years what we're doing, I think, with morbid obesity was not addressing the underlying cause of the sleep apnea. And so I think it is important. I'm trying to lose weight myself right now. It's not easy, but it is something to emphasize the importance of. In the context of the GLP-1 receptor agonist discussion, I think it's particularly important because there's this concern about sarcopenia, loss of skeletal muscle. If you lose 100 pounds, some of that's going to be muscle just by definition. The estimates vary, but roughly 20% of the weight that's lost is skeletal muscle. Some estimates are as high as 60%, but 20% in aggregate is the number I'm seeing. And so why is that a problem? Well, if you lose a lot of skeletal muscle, that drives your basal metabolic rate, which is what you need to burn calories. So if you lose your skeletal muscle, you tend to regain weight quickly because you're not burning calories with loss of skeletal muscle. So diet and exercise, I think, are important, particularly resistance exercise to maintain skeletal muscle. And Amy, correct me if I'm wrong here, but married to an endocrinologist, I know enough to be dangerous. High protein intake can also be helpful in terms of preserving skeletal muscle in addition to resistance to exercise. There are a bunch of drugs now in the pipeline. There are androgen modulators, there's miragrumab, there's other drugs that people are looking at as ways of maintaining skeletal muscle as you're losing a lot of body weight. And again, as a upper airway physiologist, I'm interested in what these drugs do to upper airway muscles and diaphragm function stuff as well. Those are studies we're now in the planning stages. So short
If I can say something about that, I feel a little bit conflicted because we're treating one problem with yet another drug, and these drugs are already very expensive. And if you look at cost-effective analyses, they are not cost-effective, even with a long-term horizon. So we need to be doing a better job, like you said, at getting people to understand that they need to be participating in behavioral change, meaning diet and physical activity changes. And so they should be getting wraparound care with programs that do lifestyle or having the availability of a dietitian who knows what she's doing and not just saying, eat less, exercise more. So because we need to remember, these are adjuncts to lifestyle or to bariatric surgery. It's not the reverse that we have drug and then lifestyle is just an add-on. So, and people will have better outcomes and will lose less lean muscle mass if actively participating in those changes. So I'll just get off my podium there.
No, I agree with you. And as I say, I know enough endocrinology to be dangerous. So I appreciate that perspective as well. The one point I'm not pushing back, I'm just clarifying. there was an MIT economist who did some cost effectiveness kind of analyses. He estimated to put everybody on GLP-1 receptor agonists that qualify now would be about $1 trillion. And the cost savings he estimated was around 200 billion based on reduced complications and stuff. And so there was a net loss there. And to your point, maybe they're not cost effective. However, a couple of anecdotes there. One is a friend whose wife is a vascular surgeon, and she's canceled 1 day per week of dialysis fistula placement. The AV fistulas are going in much less frequently because there's less dialysis going on because these patients have better outcomes. They directly attribute that to the GLP-1 receptor agonist, not anything else. And so there are some cost savings that probably aren't fully captured with these models. The other thing I'll say clinically, which I see is I have many patients tell me their grocery bills go down. They're eating one meal less per day, and at $20 a meal, that's $600 a month. Alcohol intake goes down, tobacco intake goes down, gambling goes down. So there are lots of economics is complicated. It's easy to say they're not cost effective, but talking to patients, they say it's well worth the $500 a month that Lilly Direct is charging for tirzepatide because they save more than that on food, which sounds a little silly, but it's true.
That's a great point. Well, thank you. We really appreciate your presentation and great discussion. And thank you again, Phil.
Thank you. Kathy, you going to Singapore? I'll see you there. Okay.
All right, thanks.
Take care.
Sure.